Hi, everybody. Welcome to episode number 136 of Tough to Treat. And this is Erica Mello. And this is a shorty, as we say, clinical pearl video entitled What to Do When Your Patient Plateaus. So, this is a clinical pearl video I recorded a couple of years ago, but I also wanted just to briefly introduce it because I wanted to add to it. So, the most obvious reason or culprit, so to speak, is that there is a secondary issue that has cropped up as your patient progresses into a higher load program. So, and I talk about going back to the narrative and going back to the movement and injury history. Okay? It's not that you missed it, it's just that something just crops up. But what I also want to add is that sometimes the exercise can be too difficult or it can actually be too easy. So I think, we miss those intermediate levels of exercise sometimes. And so what I would advise you all to do, if you know the exercise that you're going to give your patient, usually in your P of your SOAP note, right? Next visit, I will do this. Doesn't happen all the time, right? But if you have somebody that is on a specific program and you know exactly what they want to do, or you have a good idea of the exercises that you're going to trial them at the beginning of the session, because the purpose of all of this is to get your patient to move more optimally, okay? Or to get them back to an activity or a sport or something that they enjoy doing. So if you're going to give somebody, let's say, lunges, for example, or a split squat, trial it at the beginning of the session. And if that's the next logical progression in your program, then what I would suggest you do is trial it, look at them first, and then get your hands on them and see what should be moving and is not, or vice versa. And it's a great habit actually to get into, because there are many times when I've trialed exercise at the beginning and the patient is just not moving optimally. There's certain muscles that need to get released or certain other areas of the body that I need to focus on. And if I just gave them that exercise without looking at it, they probably would have come back worse. Forget the plateau, they would have come back worse, right? So you really want to think about, just try to do this with a few of your harder patients. Think about an exercise that you want to give them and trial it at the beginning. If they look great doing it, awesome. If they don't, figure out why. Okay? Is there a secondary issue? Is there a muscular imbalance in, let's say, for example, we'll do split squats, right? Is there a muscular imbalance in their back foot? Or if their hip is the issue, if there's a muscular imbalance in their hip, does something need to get released? Or does something need to get trained? So I would highly advise all of you to get into that habit. And if your patient is still plateauing, then there could be something in the history. Okay, so I hope you enjoy the episode. And if you've not yet left us a review on Apple Podcasts, we would really appreciate it. Susan and I rely heavily on these testimonials. And if you've found value with our content, we would really hope that you could leave us a review on iTunes. And our website, as always, is toughtotreat.com. There's a wealth of content in there, and feel free to go and type in the search bar any sort of subject that you're more interested in. It could be pelvic girdle pain, it could be neck pain, headaches, and all the episodes that we've devoted to that topic or a keyword in the description will come up, because we all know that we're at episode 136. We all know, there are many people who haven't listened to all of them, right? So especially the ones at the beginning when we first started out. So I hope you enjoy it, and we'll see you on the next episode. What do you do when your patient plateaus? We've all been there. So, what happens? What do you think? You get frustrated? You blame the patient? No, you don't, right? It's not their fault. It's not your fault, right? It's part of the patient process, right? And so there are a couple of reasons that I believe that I've seen that have caused patients of mine to sort of stagnate. They're doing okay, but they want to do something else and they can't. So it's more of a higher load activity, generally, running, things like that. But the first reason is that the patient could have a secondary driver, a secondary region of the body that you need to treat. Not the way you've treated the primary region, but you need to treat the secondary area just a little bit more than you've been doing, because you've been probably not treating it at all. So I'll give you an example in a second. So the first one is there's another region of the body that's driving or that's causing this patient to plateau, and it's just you haven't addressed it yet, and it's probably something in their movement history. So go back on their movement history, see what areas you've put on your priority list. If the patient has an ankle sprain in their history and you haven't addressed it, take a look. And the second reason is when you start to load their system. So the patient has one area of the body you've been treating, it's been great, and then all of a sudden you load heavily in the system, whether it's weight or multiple movement challenges, 3D, and then the patient fails, or you see some loss of control. That is another time when you need to look at a secondary region. The patient could be worse, actually. So that as well. So it's really more of a timing issue with load, or it's something that you didn't miss in the beginning. It's just not showing up until now because you've peeled all the layers of the onion off, as I say to patients. I'm peeling the layers of the onion, and now I'm uncovering other things. So as a patient example, a patient of mine, I saw her last year. She had left foot and left knee and left hip pain, and her driver was in her thorax. She had loss of control. We're working that, treating that. It was beautiful. We ended up, doing a lot of jumping, side jumping, jump rope, and all of a sudden her foot started to hurt. I was like, what? Your foot? And she had a little history of an ankle sprain there, which I knew, but I went back to my eval, and I'm like, I didn't miss it. It wasn't showing up then, right? So if it was showing up then you go back and say, well, okay, next time I won't miss that. But it wasn't showing up then in her case. It was only showing up when I loaded her system. So you don't have to, give her a whole foot progression. This is not the primary driver, not the primary issue. So with the secondaries, you can give them specific exercise. It doesn't have to be, seated heel raises, squats. It doesn't have to be that way, right? So I think it's important that we recognize that we don't have to give them a ton of things to do, but know that we need to address that region of the body. My last example is a patient of mine who had just a problem back bending. And her main driver was actually, her foot and a little bit of trunk control, but it was really her foot. I know she couldn't back bend, but her driver was her foot. And we did a lot of work on her foot. She got a lot better. And then she started to pick up heavy things. And we weren't at that point in the program yet. So I saw a lot of loss of control. Her meaningful movement, so to speak, was a back bend. So the minute she picked up a 50-pound box or tried to with her husband, her back bend got way worse and she had a lot of symptoms. So when you're progressing somebody through a foot program, you're not so focused very much at the beginning on lifting mechanics and lifting. And with her, once again, it was the heavy load. And I looked at her when she lifted heavy, and you could see the non-optimal strategies in her lumbar spine and her pelvis. So it turned out that her pelvis was a secondary issue. And it's not that I missed it at the beginning, it just didn't once again show up until we loaded the system. So I started doing some work with her within the pelvis, and she's getting much better. I'm actually still currently treating her. So the clinical reasoning is crucial when you have this scenario, all right? Just think out of the box, think of another region that may be in their history, okay? And with her, she was postpartum about 3-4 years. I think once you're postpartum, you're always postpartum. And with her, and she did say something, ironically, when I was working on her, she's like, wrapping a sweater around my waist makes me feel better. It's like pelvic compression. So there you go. Hope it helps.